morning. My name is Shelley Greenfield. I head up with Sherry Kaplan, the Health Policy Research Institute at UC Irvine, and I'm also a professor of medicine at UC Irvine. I'm going to be moderating this session this morning, and welcome. Now, you can see this slide. When Paul and Margaret asked me to moderate this session, they didn't know, how could they, why would they, that the very first study in the United States and probably the world to directly compare allied health people to physicians was done by our group published in 1978. And actually, the truth is there's been very few randomized trials. This is randomized against outcomes. In fact, Michael was done at Kaiser Inglewood at the time. So, our group here is continuing this work with community coaches. And my colleague and wife, Sherry Kaplan, is talking at the other Institute of Medicine in Washington this weekend, or Monday, on community coaches helping patients with chronic disease to participate more in their care and take more control of their disease. So we have a great interest in what is said by the panel this morning, and we're greatly looking forward to it. So what I'm going to do is each of the speakers will talk for about 20 minutes. I'll introduce them one by one. We'll hold questions to the end, and then we'll proceed. The first speaker this morning is Timothy Hoff, who is Associate Professor of Management, Healthcare Systems, and Health Policy at Northeastern in Boston. He's actually on his way on the turnpike, just moving there. He's a nationally recognized organizational and medical sociologist in the study of health reform implementation, healthcare quality, primary care, and physician behavior. He has lots of publications, including a book called Practice Under Pressure, Primary Care Physicians and Their Work in the 21st Century. He is, among other things, he's currently PI on an ARC grant studying patient-centered medical home implementation, which is a critical issue. And in addition to his academic research, Dr. Hoff has consulted with many public and private sector organizations on health services redesign and governance issues. Dr. Hoff.
It's a pleasure to be here. I've never been here before. I really appreciated the invitation. I can tell you that we would probably solve the whole customer service issue in healthcare if we could just take someone like Margaret Wong and clone her like maybe 50,000 times and just spread her across the United States into the healthcare system, because it's a tremendously well-organized conference, and I've really enjoyed it. It's good for academics to sort of get out in the real world once in a while. I'll go back to my zoo the beginning of next week. I'm a sociologist, so I'm not going to present. You saw a lot of trend lines, bar graphs, forecasts yesterday. I don't like that kind of stuff. It sort of creeps me out a little bit. I deal in people. I like to study people. I like to study dynamics in the workplace. I like to study what goes on in organizations. So I'm going to talk from that perspective, mainly. But I really want you to keep in mind 3 takeaway points from what I'm going to say. One is we don't have enough physicians. We probably will not have enough physicians. And so we're going to need to account for that in the system. Okay, regardless of what figures you want to believe, not believe, whether you believe double AMC or this forecast or that forecast, the fact is they all pretty much line up. I mean, we're not going to have enough doctors. And that may not necessarily be a bad thing, but it is going to promote and spur innovation. And we're going to have to account for this. The reason we're going to have to account for this is because the second point is, in the healthcare system that's coming, access is going to be everything. Okay? We've sort of played around for the last 10 or 15 years, the quality movement. We've really focused on quality. I think access is going to now become the tsunami that envelops us all. And quality will still be extremely important, but we're going to have to establish contact points to get people to be able to get into care. I mean, I work now in a state, Massachusetts, that's been grappling with this for, 5 or 6 years, okay? And they're still trying to get a handle on it in terms of getting people in to see primary care doctors, getting wait times down. They're the bellwether for the rest of the nation, okay? So, and the third point is, when we try and think about workforce and physician shortage, I think there's a value to understanding what's happening on the ground. I think more of us need to get inside these organizations, these delivery sites, whether they're hospitals or ambulatory care clinics, whatever, and really understand what kind of work is going on, how is work changing in healthcare, who can really do that work now, and who can't, okay, and how should it be done? These are 3 questions that we're trying to answer from the macro level. To put systems in place and to rationalize and standardize and bring technology in, and that's all well and good, but at some point we got to get in and really look at how is all this stuff playing out on the front lines. And I think we need to, so those are the 3 points I want you to just keep in mind. So here are some realities. Expected shortages, okay? There's a AAMC report I was looking at before I came here. Report in 2008 in Florida. Quarter of their docs are over 65, only 10% are under the age of 35. California, 2009 report, quarter of physicians are over the age of 55. 2012 Massachusetts report, 7 physician specialties have critical or severe shortage labels, okay? These include family medicine, internal medicine, general surgery, psychiatry, dermatology. 2006 report in Michigan, they expect by 2020 they'll have a physician shortage where they'll have a gap of 12%, 12% shortage of docs in terms of what they need. 2008 report in Minnesota, 45% of docs are over the age of 50. Okay, nationally there's expected to be shortages, and there already are in areas such as cardiology, anesthesia, critical care, dermatology, emergency medicine, gastroenterology, general surgery, geriatrics, oncology. Basically the entire profession. There's a shortage. So again, whether or not you believe these numbers, whether or not, obviously things are going to happen on the demand side and have to happen, but the reality is we're probably going to have a physician shortage. Primary care has been particularly affected. They've already been affected, okay? The fact is people aren't going into primary care medicine. I don't know that that's really going to change. Okay, I did a book on primary care. I interviewed a lot of medical students. I interviewed a lot of young doctors. It's going to take a lot for young people in medical school to come back to primary care and the numbers that we need. And think about the numbers that we need, okay? AAMC expects a shortage by 2020 of 60,000 primary care physicians, okay? There's an article I read the other day about how 10 of the top medical schools don't have primary care training. And they're being pushed to sort of bring primary care into their schools. Even if all 10 of those schools started primary care programs tomorrow and produced 100 graduates each year, okay, that would still, when you multiply it out, only create over time 10,000 of the needed 60,000 primary care physicians. All right, so if that's our solution to get more medical schools to create primary care training programs, it ain't going to be enough. And chances are most of them may not do it anyway. So we need to be careful of what we're going to put our faith in. And I think the reality is the answer is going to come perhaps from other types of providers and other delivery structures, which I'll talk about in a moment. We have an aging physician workforce. Okay, 1/3 of primary care docs nationally are over the age of 55. A lot of them are going to start retiring soon. I can tell you, talking with a lot of them, my own feeling is a lot of them wish they could retire now. That's how a lot of them seem to feel about the system they're in, okay? Remember, these older primary care docs, they grew up in a system that was very different. And if we want to fool ourselves and think that a lot of them are happy about what's happened, they're not. And so they're going to be out-migrating. We're going to have some new ones coming in. But remember, the new ones are going to be very different, all right? I like to tell this little sort of anecdote. I'm a Generation Xer. I'm in that nether world between the millennials that get all the attention and the baby boomers that get all the attention. I never got any attention. I'm the lost generation, okay? So, and I'm proud of that in a way. I missed the baby boom by 1 year. I was born in 1965. I guess the baby boom technically cut off in 1964. And I always said, well, I feel proud of that. But when I look at the baby boomers, to sum up the differences in generations, I wake up in the morning, and when I think like a baby boomer, I think, I got to go to work. I got to work all day. I got to contribute. I got to work really hard. I got to balance everything in my life. But I got to work, and I got to be committed to my work, and my career matters, et cetera, et cetera. When I wake up as a millennial, I go, let me have a cup of coffee. Let me think about what I want to do today. I'm going to work, but, I really want to kayak, or I want to, I want to hang out a little bit. I want to see my friends. I want to have a really good job, and I want to have a really good career. But that's not everything to me, okay? Hence the difference between the generations. That's going to seep into the physicians of tomorrow will be very different from the physicians of today. Not necessarily in a bad way, but they're going to be different. I can tell you stories of the female primary care doctor who I sat in her office interviewing her at 1 o'clock. And, she said, my biggest worry every day is being able to get out at 2 o'clock so I can pick my child up from daycare. Okay, this is a physician, all right? And her inability to convince her partners to give her a more flexible work schedule. I can tell you about the medical student I interviewed who said, yeah, a lot of people in my graduating class are interested in pathology because, it's great hours, great pay, and you don't even have to see live patients if you don't want to. Okay? It's different, and these doctors are going to be different. They're going to be more technologically savvy. They're going to be more willing to work for a salary, which is good because hospitals are hiring all the doctors now, so they're going to be employees. But their work ethic may be different, and what they're willing to put into the career may be a little different, and maybe the way they connect with patients and with the medical care system will be different. So that's just something we need to keep in mind. And obviously, the other reality is we keep getting sicker as a nation, okay? And that's not expected to discontinue anytime soon. If you look at the state expectations, state rates of obesity, a report that came out a few months ago, it's staggering. In most states, the rates of obesity in the general population or overweight are expected to double, despite all that we're doing. Okay, so a few other realities that I think are less understood, okay? One is that I don't think physicians are a really happy group at the moment. Medscape did a big survey last year, 24,000 physicians. Almost half of them said they would never become doctors again if they had the choice. Now, again, we all sit back and go, oh, doctors, they always complain about everything. And surveys go up and down. Some years maybe doctors are more satisfied than others. But if you look at all the satisfaction data and the data about, career regret, things like that, it's starting to tell a story. Physicians are under attack in a lot of ways. They are getting asked to do an awful lot of things, and an awful lot of things that they didn't necessarily sign on for. And I think younger or older, increasingly, a lot of them are, if not unhappy, somewhat increasingly ambivalent about what they're supposed to do and what they're really, what it's all about to be a doctor. And I think we have to take heed of that, because what the management literature will show you is unhappy workers are less productive workers. Okay, and if we're trying to get physicians, and this applies to nurses, PAs, really all healthcare workers, if we're going to make them more productive on the ground, we're going to have to address these issues of what motivates them and what kind of work environments we really should create for them, because we do not want unhappy, less motivated workers out there, because it's going to affect things like efficiency and value. Physicians are becoming employees fast. This is like, I call this back to the future. Hospitals were hiring all the primary care docs, for example, 15 years ago. They're doing it again. This, I think, is a permanent trend, okay? In part because younger doctors coming out have no problem working up for a salary. In fact, for some of them, it gives them more flexibility to do other things in their life. So this is a permanent trend, but remember, boy, hospitals, doctors, wow, that's going to be, there's going to be some dynamics there that we're going to have to think about. There's some de-skilling going on in the profession. I've seen this in my primary care research, medical records. Primary care doctors don't go to the hospital anymore. That's a de-skilling effect on them. I talk to a lot of primary care doctors, younger ones, who say, I'm never in the hospital, I don't see my patients when they're at their sickest. It makes me less confident in my decision making. Maybe it makes me refer out quicker because I don't feel as competent to be able to assess a situation because I don't have a lot of experience in looking at that situation because the hospitalist takes care of the patient when they're in the hospital. Or I don't see specialists much anymore because I don't get out of my office. And so I can't get that knowledge connection. So EMRs, same thing. I mean, EMRs, I've done some studies where EMRs, a lot of doctors have talked about feeling that what they look at mostly is cut and paste stuff, that they, specialists send them notes and they see the same note for 4 different diabetics from the same specialist. And they go, wait a minute, which one is the note for? And to them, they feel like there's a real voltage drop of expertise and information that's being transmitted to them. That's potentially a deskilling effect, okay? So, and when you look at the business model in something like primary care, I mean, what does a primary care practice really do now? What's the complexity of care that they deliver? And so these things we have to understand. These are things that are happening at the micro level, but they are changing the way the workforce, the physician workforce, they're changing their ability to perhaps do certain things or not do certain things in their work. Okay, so what does these realities mean? First is, I think as others have pointed out, we're entering the age of disruptive innovation in healthcare, certainly in primary care. Disruptive innovation means somebody comes in and finds a better, cheaper way to do something. Initially, they create a new market for it, but then over time, as that market gains credibility and foothold, it starts to take over other parts of the market. This is what you see happening in primary care. Retail clinics are disruptive innovation. The uses of nurses and physician assistants to provide primary care is a disruptive innovation. Okay, but that's upon us because we don't have enough physicians and we don't have enough contact points in primary care. And contact points will matter. Contact points will be everything. This is what Massachusetts is realizing. There are not a lot of primary care practices or doctors in rural areas, in inner cities, and you will see disruptive innovation take hold, if only because of those reasons. The opportunity to lower costs and enhance access is there in primary care. And people will step in and try and make it work. Right now, primary care medicine, the patient-centered medical home, for example, which to me is something we should, to me that's going to end up potentially being more of a boutique model of care. It's a high-cost model of care if you do it right. A lot of the early studies are showing that, some things like ED use and inpatient admissions might decline, but the expenses on the primary care side go way up, right? If you do prevention right, you're going to spend a lot more. There was a study a few years ago that said if every primary care doctor did the right amount of prevention in their workdays would extend by 8 hours, each of them, okay? So, the patient-centered medical home, in the end, I think we're going to realize it has some really good things associated with it around quality, but it's going to end up costing money. It's not going to save anybody that much money, all right? So that's a high overhead sort of solution to the problem, okay? We're going to get more jurisdictional competition in primary care. So what's about to happen and what's starting to happen already is as nurse practitioners, PAs, nurse practitioners and nurses particularly push for greater scope of practice, greater independence, the medical profession steps in and you have these battles sort of playing out in different states. And we're going to have a period of time where a lot of resources and time are going to be, dumped into this sort of battle. And I don't know in the end that it's really going to be productive because I think what's going to happen is what's going to happen. If access is the issue and legislators and governments know that access is the issue, I think certain things are going to happen whether the medical profession wants it or not. And one of those things is we're already seeing is nurses are going to get greater ability to work independently. And that's already happened. 27 states, I think, or thereabouts have expanded authority to nurses, particularly in primary care. And more of that's going to happen. Because, the average politician is going to think, I got to get health care to that area of my state. I got to get health care to my district, and that's the #1 priority. And we're entering a period, with this disruptive innovation, we're entering a period of a lot of trial and error, okay? And I think it's sort of like, I call it the Wild West. We're in the Wild West right now, where somebody can come into a town and set up a shop or, do whatever they want to do, and there's no marshal around really to stop them. And I think we're going to have a lot of trial and error, a lot of untested care models out there, and I think as a researcher, I would say we're going to need to slow down and try and evaluate some of these things in a very effective way. I mean, the medical home, we just laid that out there, and now we're just starting to get research and information back that's showing us, maybe there's some things we should do differently. My last 2 slides. One is, again, bringing it back to physicians. These, I think, are some determining questions to think about when we think about how the physician shortage is going to play out and what that shortage is going to mean for changing the way the delivery system's structured. First is, this is a very simple question, but no one, I think, can answer it yet. To what degree does the system and government think physicians can be replaced by technology and non-physicians? If we start to answer that question, then we're going to see a system, potentially morph and evolve very quickly. In primary care, I think we're starting to answer it. What we're saying is they can. Non-physician providers and technology can do an awful lot to deliver good primary care, particularly in chronic disease management, for example, or dealing with populations that all have the same situation. We don't need as many physicians. And I think that as long as we have the information and the science to conclude that and feel comfortable with that, that's fine. But in other areas, we're going to have to think long and hard about that because it gets a lot potentially more complex when you think about other areas of healthcare. I will tell you, though, I'm doing a medical home project now, grant, and looking at medical home implementation for older adults. And there I can see the primary care doctor mattering an awful lot because the older adults are really complex. None of them want to use technology. They want to talk to their doctor on the phone. They don't want to talk to the nurse. They don't want to talk to the medical assistant. And what the doctor will say is, I'm the one that they trust. I'm the one. Now, again, that might change 10 years from now with the new batch of older adults. But right now, technology isn't helping doctors deliver medical home care to their older adults. Doctors are helping doctors deliver medical care to their older adults. Another question, how will the medical profession meet the challenge? Will they fight? Will they try and come on board with some of these models and some of these new structures? Or will they go into a protracted period of sort of the really trying to combat any encroachments on their turf? Can an emphasis on prevention and integration ease the pressures on the physician workforce? I mean, there's a lot of potential if we can really integrate care, develop really true team-based models of care, for example, develop structures that are highly integrated for the patient, that we won't need as many as physicians, all right? But the question is, that integration has never worked well in healthcare, and I don't know why it's going to work well now unless we drop a lot of financial incentives on the system to do that. And can mutual interdependencies be solidified in the system? So really the way to deal with this physician shortage and to deal with the fact we're going to have fewer physicians is to also try and get the system to become more highly dependent, each component on each other, all right? So the last couple of points, predictions. I tended to focus on innovation here, in relation to the physician shortage stuff. I think at the ground level, at the practice level, what you're going to see is technology use among the workforce remaining flat, okay? You see a lot of studies now coming out on EMRs that show doctors, providers don't use them the way we want to. They don't have the time to use them. The work environment is still not set up for physicians especially to use EMRs in the way we want them to, for example. So what you're going to have is health IT being used mainly for what I call organizational level analytics. Being able to track populations, being able to look at patterns of care. So I think the provider level embrace of technology will remain ambivalent at best, okay? And that's going to slow value creation if we think technology can actually make a doctor's work life easier. What I see now in my own world is that it makes their work life harder and more complicated. So we're going to need to think about that. I think it's entirely possible that we're going to have a patient backlash coming with the whole issue of technology. I think some of the innovation we call innovation in healthcare is way too slow for the younger generation and way too fast for the older. I mean, I teach at a university, and I can tell you, and all of you who have kids, I mean, a 17 or 18-year-old boy, they're so far ahead, I don't even understand some of the stuff they're talking about when they talk about the technology they're using, the apps, how to do this, how to do that. And when we look at healthcare, we think we're doing so much technologically. If you probably talk to a 17-year-old, they'd be like, dude, well, you can do better than that. Come on. Whoa, I can access my EMR through the computer? Whoa. That's so 2005. I mean. So, I think we got to realize that if we really want to use technology, particularly for the young cohort, we're actually going to have to speed things up and innovate even more. And then finally, disruptive means entry-level new market creation. So I think with primary care, what you're going to see is increasingly a tiered system, where you're going to have medical home care, concierge care, direct primary care for, the well-insured and the people who can afford more out-of-pocket expenses. They can have retainer-based sort of care. You're going to see, though, more of the access points and the use of non-physicians and new structures really in the areas that don't have primary care present and primary care access at present. So I will stop there, and again, thank you for the opportunity to be here. Thank you.